Hello, and welcome to today's webinar with IOP ebook author Professor Malcolm Sperrin. Professor Sperrin will be reviewing his latest book, Scientific Basis of the Royal College of Radiologists Fellowship, Illustrated Questions and Answers. During the webinar, we welcome your questions, so please use the Q&A facility to send them in any time during the talk. Professor Sperrin will then try and answer as many questions as he can at the end of the presentation, and we will respond to any unanswered questions once the webinar is over. On that note, I will hand over to you, Malcolm. Thank you very much.
Thank you. Well, good afternoon to everybody from Bristol in the UK. I'm Professor Malcolm Sperrin, and I'm Director of Medical Physics at the Royal Berkshire Hospital in Reading. But in addition to my day job, which is mostly in nuclear medicine and clinical engineering and radiation protection, I also do a lot of work on professional standards and training for a variety of medical professionals, most especially the radiologists. And this book was intended initially to be a supporting text for those who are going for the fellowship exams for the Royal College of Radiologists. But it's evolved into something far more, and I'll be going through what the various benefits of this book are and how they support the medical profession, and why, at least in my view, it's so important. So let's just move on to the next slide. Now, the question that sometimes arises is why medical science is important. You could see it in many people's eyes as medical science is a valuable profession but separate from that of medicine itself. But medicine has come a long way since the days that most people imagine, where you're looking at the laying on the hands of the patient to actually determine where things hurt and where bruises are and so on. So medical science now informs the radiologists and many other medical professionals on aspects such as safety. That if you have an X-ray, most of us will know that if you impart radiation on somebody, then there is a certain risk to it. So the medical science will inform on that safety. But it also applies equally to where other modalities that people traditionally don't associate with such risks, such as medical imaging associated with ultrasound, or for MRI, magnetic resonance imaging, they also have risks associated with them, all of which need to be taken into account. Now that's a particularly important point that we do try and get across in this book, because it's all very well choosing the safest possible technique. So you might choose ultrasound as a technique for diagnosing a condition, for instance, but if that as a scientific concept isn't capable of picking up the origin of the pain or where a disease might be, it is really useless. So you need to make sure that you have an awareness of the safety of the various modalities that are available to the radiologist. So the techniques, how they work, is also very important. People need to know how to maximize the potential of a particular imaging modality. In ultrasound, you might rather perversely turn down the power to get a better image. And that is important knowledge for the radiologist. Research is very important. If you have a new technique that you're trying to use to determine the origin of a disease, then the research can provide a lot of information about which is the best modality to use and what it can and can't show. And lastly, on this little list here, is about legislation. We all now live in a world that is governed to some extent by legislation and guidance. So for instance, if we irradiate a patient to excess, we can be prosecuted. Now it's up to our professional judgment whether or not the patient does need that X-ray, but we need to be informed about what the potential risk is to the patient, and also to us, of course. If you irradiate a patient, you'll end up with some radiation coming back to you as the medical professional. And this book is intended to provide a degree of training and information for exactly that. So all of those 4 points are vital. That's really what we're trying to get across as part of the training scheme. Now, deliberately, what we haven't done here is relate this specifically to one medical professional over another. The Royal College of Radiologists is by far the biggest medical profession that this relates to, but all medical professionals will need to be aware of concepts similar to those that I've described so far. So this book is, whilst aimed principally at the radiologists. It is not exclusively at the radiologists. What we're certainly not trying to do is to provide an in-depth understanding of equations such as you can see on the right here. Now these are what's known as the Bloch equations, and they provide a mathematical understanding of the MRI concept or the MRI technique. We are not trying to get that across. We are not training the radiologists to be scientific and mathematical specialists. We're trying to train the radiologists to have an informed awareness of what the key points are. Now, the sorts of concepts which we are trying to get across through this book is to ensure that where those doctors have trouble with certain key concepts. Now, there are some areas that are more difficult traditionally than others, and what we want to do is to try and concentrate and hone in on how we can actually help those. Now, a lot of books, what they will do is that they will just present the information in toto and not really concentrate on the difficult concepts. What I've been particularly keen to do is to ensure that we focus on those areas which traditionally have turned out to be more difficult. And you'll see, for those of you, if you've picked the book up and how to browse through it, we will cover the areas which, in our experience, have proven to be difficult. And also the complexities. There are some difficulties that junior radiologists sometimes come across. All imaging modalities, for instance, will have competing influences on the decision-making process. You might on an X-ray want to increase the power, but the downside of doing that is to increase the radiation risk to the patient. Increasing the power will improve the image quality, decreasing it will decrease the image quality. So there's a multifactorial power play there. So those are some of the complexities that we need to get across and which we do address. Legislation, this is necessarily a changing beast, but we do cover, quite rightly so, we do cover a lot of the national and international guidance that relates to patient and staff safety. And this would be, in the UK, we have what's known as the Ionising Radiation Regulations 99, and also Conceptus Irma, which is the Ionising Radiation Medical Exposure Regulations. And all of those need to be taken into account through a process known as justification and optimization. And also guidance. What is best practice? So the various Royal Colleges, the Society of Radiographers, various institutes will provide guidance on the best way of doing things. So you then have a degree of utility in your knowledge. You know how to convert from what your theoretical knowledge is to use the guidance to the maximum benefit of the patient. And also new techniques. New techniques are coming along all the time, and certainly it's my intent to ensure that the new techniques are included in this textbook so that we enable the junior radiologists or those who want to buy the book to remain current in these sciences to be fully aware of the new techniques that are coming along. Now, new techniques might, for instance, be optical tomography, which we don't include at the moment, but we will do in the very near future, and also terahertz imaging, to name two. So those are both important for medical diagnostics, but are not really currently used, but are likely to be in the next 2, 3, 4 years. So those will be included. And what we're really trying to do is to get those concepts across. So we as individuals will benefit from those, and the radiologists will be informed in their optimal usage. Now, just some examples to try and get these concepts across is that one question that sometimes comes in my direction is a CT, so that's a computed tomograph of the chest, better than the VQ scan? Now, you need to understand quite a lot behind that. But essentially, the CT, most people know what a CT is, and you can see an image of a CT chest through the lungs and the top of those two, or the upper of those two images. And at the bottom, we have what's known as a VQ scan, and the VQ stands for ventilation quotient, and that's a nuclear medicine study. So CT is X-ray, tomographic X-ray, and at the bottom it's a nuclear medicine technique, and both of these will be covered in the book and form part of the training, the basic medical scientific training of the radiologists. Now, they can be used to determine a number of different conditions, but the one which often comes in my direction is PE, or pulmonary embolism, and that has one of a number of different origins. It can be associated with long-distance flight, it can be associated with many other conditions, but it is very, very important to be able to diagnose it accurately. Now, the sorts of factors which we do need to take into account here is things such as contrast, that if you've got a condition, you need to ensure that you use the technique which is relevant to the visualization of that condition. It is no point whatsoever, if you're looking for a pulmonary embolus, to use ultrasound. You can't see it. It is just physically impossible to see it. So really the only techniques you've got are CT or VQ. The next point down that you need to take into account is something like resolution. That if a feature is small, say 15, 20 microns, that's 0.2 of a millimeter, is your system capable of looking at that? Is it capable of seeing it? So that needs to be very much taken into account. And you could go down this list such as risk. Now, one factor that we do get across to the radiologists and is covered in the book is the establishment of risk, how you actually assess that risk. Now, in the case of CT, most people will be aware that you irradiate the patient as you might a slice. So imagine a slice going through a patient. So that patient is irradiated, but as soon as you turn off the radiation, the patient gets up and walks away and ceases to be radioactive. The patient never themselves becomes radioactive. Now, in the case of nuclear medicine, in the VQ scan, you actually administer a radioactive drug to the patient. So when the imaging process is finished, the patient will then walk away and remains radioactive for a short amount of time, but it is still a significant amount of time. So you need to be careful that the patient doesn't go and mix with other more susceptible members of society, so that, for instance, young children, at least for a while. And we do make it quite clear to the radiologists that they actually have to understand the decay process of that radiation and why nuclear medicine results in a radioactive patient but CT doesn't. And it's all to do with the systemic nature of the radiation which is given in nuclear medicine. So that is quite a complex understanding, quite a complex description of these two processes that just goes beyond the medical nature of this condition. We also need to know about cost and availability of the techniques. Nuclear medicine is quite specialist. Its availability is certainly far less than that of CT, and hence in some hospitals you may decide that whilst you might want nuclear medicine, you have to use CT and therefore become aware of the more niche aspects of how the technique can be used for diagnosing this condition. Waiting time, nothing's perfect, patients have to wait, but if the waiting time is greater than the how the condition is developing, then there's no point in waiting for that particular technique, even if it is the perfect technique. And the patient tolerance and also allergies which may affect your ability to perform that technique, especially where you're giving drugs. So what we were trying to do is to give an overall view of those and other key points in relation to the choice and use of imaging techniques, not necessarily for set conditions, but so that it can actually inform on how that clinician will manage that patient, both currently and also in the future. So that's quite a good example about what we're trying to get across. Now, image quality is also very important. What we've got here is two images of a developing fetus. On the left, the darker of the two images shows this looks like a fetus at about 30 weeks, and on the right, so slightly older. But you can see on these, it's much easier to see on a proper imaging screen, but hopefully you can see on these that the left-hand image, the image quality, is much better than that on the right. And this is partly to do with the fact that the image on the left is very new, the one on the right is about 10 or 12 years old. Both of diagnostic use, although the one on the left has a greater diagnostic use. And if you need to get further information on this, you can, for instance, on the one on the left-hand side, you can see the bladder, you can see the heart chambers, the various structures of the ribs, and also structures around the navel cavity and the front and the back of the head and so on. The one on the right is a bit more difficult. So image quality isn't just one of making the image look nice, it is also a question of increasing the diagnostic potential. And this is a key point of the training that we provide, in that it's all very well being able to form an image, anybody can do that, it's a question of forming the best image for your intended purpose. So we've moved on from the key scientific concepts, and now we're starting to talk about some of the more radiographic aspects, the aspects of technique that relate to the formation of the image. And that is a very, very important part of the radiologist's training, is how you actually end up with an image that is as good as it's possible to get. So those are very good examples of the importance of image quality. And if we're looking at images from CT and MRI, they are far, far more difficult to obtain a high quality image than in the case of ultrasound, which is what we're looking at here. But the same general concepts, the same general guidelines still apply. Now, risk versus data. So there is a crossover here between scientific medical techniques and also the more general aspects of societal radiation protection. On the left, you've got a map of the radiation outflow from the Fukushima disaster some years ago now. And on the right, this is a nuclear medicine image of the uptake of technetium in the kidneys and also in the bladder. Now, most people would look at this and think there is no connection, but in actual fact, it is largely the same technology, it is the same scientific concept. On the right-hand side, we want to know that when we give a patient a dose of radioactive drug, how that is going to collect in the kidneys, how that's going to flow to the bladder, where it's going to go afterwards, and what the risks of the patient are, and also the risk to the general population. When the patient goes to the toilet, the urine, for instance, is going to be radioactive. Now, the only difference between the image on the left and the image on the right, or there's two differences really. One is clearly, one's a geographical map and the other's a medical image. But the other point is about scale. If you equate the two, then the two concepts become very, very similar. So in Fukushima, what you found is that instead of having a radiation dose administered to the patient, there was a radiation that was accidentally released into the environment. But that then flows largely out to sea, and what you're looking at then is the possibility of a dose enhancement to anybody who is sailing across that sea, and eventually you could pick up that radiation on some of the shores on the United States, so on the western shores of the United States. So there is a lot of technology and a lot of scientific content that connects these two. And that is a point that we do try and get across to the radiologists, is that it's not sufficient to relate the knowledge specifically to one application or the other. It is very helpful to encourage the junior radiologists to understand the process of radiation deposition and recovery and risk in more general concepts, because you never quite know where that radiation risk is next going to arise. Now, we've shown on the right-hand side the radiation that's deposited in that patient, but that could also equally well be a radioactive spill or the deposition arising from a new technique. Now, communication, this is an important area, is that most patients, when they present for imaging, will be anxious, and primarily anxious about their underlying condition. Part of our job is to ensure that that concern is at least partly mitigated by an awareness of what risks arise from the imaging process itself. So in the centre, the central image, the top central image, that's a straightforward chest X-ray, and that has associated with it a certain radioactive dose, and hence a risk to that patient as the patient ages. But likewise, you get a radiation dose from a flight across the Atlantic, and that's the reason why we've got that aeroplane taking off, and also from natural radon, which is the picture in there of rocks in the UK in an area known as Dartmoor. And by far the biggest radiation dose from those three images is from the rocks, and that's really quite substantial. That is many, many, many times greater than the radiation dose from an X-ray, and which in turn is a bit greater than that from an aeroplane. People don't worry about the radiation dose when they go on to a holiday in those geographical regions, and they generally don't worry about the radiation dose from an aeroplane. But there is something about the medical imaging process that does get people worried. It's right to be worried, but it's also right to enable the radiologists to equate that risk to other areas where the patient feel more comfortable. And at the bottom, that long snake-like thing is an MR scan, and there are risks with MR as well. So that is using a technique using phased array detectors. Now, we need to be able to teach the radiologists about the method of image reconstruction. And this is actually a good example, because that spine, you can see the bony parts of the spine and the soft pads in between the discs. And you can use this to identify where the risk arises patient might be referring, for instance, with painful back, and that could be slip disc amongst other things. But what this image does is using a technique, as I mentioned already, about phased arrays, but that doesn't permit adequate imaging into the chest cavity or the abdominal cavity. And hence the choice of options, even in MR, is critical. If you wanted to image inside the chest cavity, you can see where the lungs are here. If you wanted a good image of those lungs, you couldn't use this particular MR technique. You'd have to choose an alternative. And it's a knowledge of those alternatives and why you have pros and cons in each case that is crucial and is covered and tested in this book. So we're nearly at the end. Another aspect is about equipment performance. Now, I'm not going to dwell on this image, but at the bottom where it says input, that could be the amount of radiation impacting upon the detector, which traditionally has been acetate film, but now is generally image plates, electronic, and the output is the grayscale that's generated. So if you like, along the bottom is going to be the radiation, and up the side is going to be what the image actually looks like. And you can adjust these electronic devices to provide an image which is given maximum contrast where you most want it. So we've got three different curves on here. These are known as gamma curves, and these enable the radiologists to use and choose which of those three curves is going to be of maximum benefit for their diagnostic purposes. One, for instance, might give the best contrast for soft tissue, where you're looking at perhaps bleeding. Another would be for general imaging, general anatomical imaging, and a third might be where you're looking for damage to bony structures, perhaps fractures. And you can choose between those three according to intent of diagnosis. And those become critical. If you choose the wrong one, you'll still get an image, but it will be suboptimal. And we are using techniques that are really pushing the boundaries of what those techniques can provide or what the modalities can provide. The choice of equipment performance, how you choose that, becomes a critical factor. And if you get that wrong, you'll be missing many an opportunity. So the aims of the text then is, one is to provide pathways to improve diagnosis. How can we help the radiologists or the other medical professionals to enhance the diagnostic potential, partly of the image, but also other techniques? We need to ensure that there's an awareness of options. If there is a choice between an ultrasound scan, which has no radiation deposition, and a CT scan, which may give us an appreciable dose of radiation, it is morally correct and probably legally correct to choose the one which presents the least risk to the patient. So an awareness of options is crucial. And that brings us on to the next point about the improved risk-benefit assessment. That assessment is justifiable in law, and that is a premise all around the world, is that if you do something to the patient that harms the patient, then that may be a clinical need, but it may also simply be is that you took your eyes off the ball. You weren't necessarily aware of what the alternatives were that would lead to a lesser patient detriment. So that improved risk-benefit and assessment is inherent in the responsibilities of the radiologists and can be tested in court, and legal pressures therefore. So one is where a patient might, there's two types of legal pressure. One is where the patient might question the judgment, which is the point I've just made, and the other one is where the radiologist has taken insufficient note of what the actual precise limits are of irradiation of the patient. And that's where you might start to look at aspects such as being a classified worker, which is a UK and European concept, but there are similar concepts from around the world. So all of those are very important. Now, that's the end of the presentation, but the purpose of the book was to provide informed commentary on those concepts and more, but also to provide help in those areas which traditionally trainees have had trouble with. But there is a third, rather more subtle point here, in that there is a need for radiologists and other healthcare professionals to ensure that they're kept up to date with the latest developments. And hence myself and the other author, who's Professor John Winder, he and I are working on making sure that the book is maintained up to the current best practice. So I'd certainly commend the book to you, and if there's any questions, I'll be delighted to take them now. Thank you very much for listening.
Thank you. Thank you very much, Malcolm. We have had a few questions come in during your presentation, so I'll just start by reading the first one out. So the first one is, as a physicist, how best can we control the side effects of radioactive decay during the treatment?
Well, it depends upon what you really mean by side effects. I mean, the easiest way is to make sure that the half-life of the radioactive material that's administered is appropriate for that patient and also for the study. If you give a radioactive drug which has a half-life that's too long, then you find that the radiation dose increases beyond any justifiable case. I mean, the other is to choose radioactive drugs which primarily give rise to gamma rays and there's no particulate radiation. All of these are really, really important factors in the choice and subsequent use and development of drugs that I do use. Sometimes you need to make sure that you use one drug because the energy of the gammas is correct, and hence you may use that as a justification for some particulate radiation, which is going to increase the dose to the patient. Now, the side effects can be radiological, and other side effects can be chemical toxic, and all of those do need to be taken into account, but there's a large number of factors which are underpinning that.
Okay, thank you. Another question is how can we diagnose the disease of cancer at early stages?
Well, there's two ways of diagnosing cancers and tumours. One is histopathology, where you're actually taking the tissue and examining it under a microscope, but that assumes that it's been suspected or diagnosed in some way. The other way of determining whether or not a cancer is present is to use what's known as functional imaging. Now, nuclear medicine is functional imaging, and what that does, it uses a drug which is going to be preferentially absorbed where the metabolism is elevated. So in the case of a cancer, a tumour of some sort, then those tumours grow because of an enhanced reproduce rate of the cells, so the metabolism is raised, and a particular drug will localise on that site. And because it's giving off gamma rays, you can image that using a gamma camera. Now, the problem with nuclear medicine, it tends to be a low resolution technique, so the cancer has to be of an appreciable size before it becomes detectable. But there is a drive to enhance that resolution and to find alternative techniques for the localization and identification of those cancers. That's a very, very big area to look at, massive area to look at.
Okay, thank you. Where is medical science heading? It's a bit of a big question.
Yes, yeah, crikey, we could write a whole series of journals on that. I think that there are two foci at the moment. Now, one is the improved image quality, that we're developing new techniques that enhance the resolution. So in particular, for instance, in nuclear medicine, where we're looking at greater resolution. Resolution in nuclear medicine might be at worst a few centimetres and at best 5 millimetres, 10 millimetres or so. So we need to improve that if we can. So the whole area of image resolution, image quality is important. But the other area is the appreciation of risk. Now, one area that I'm very keen on looking at is the reduction in radiation dose by enhancing the performance of things like detectors. And my view, and this is perhaps a little bit contentious, is that in some types of imaging, in particular imaging of the hands and feet, which aren't very radiosensitive, we are probably starting to get down to radiation doses which are of little consequence. In actual fact, there is a technique known as hormesis, in which there is an argument that the radiation provides a benefit rather than a detriment. So I think to drive down the radiation doses and a greater understanding of risk and to reduce that risk to the patient and staff is one of the two areas. The other area, like I say, is image quality, and the two do go hand in hand.
Okay, I think following on from that one about image quality then, we've got another question which asks, why can't we have automated improvement of image quality?
The problem with the automated improvement is because if you improve an image in some way, then there is some other aspect to the image that you're sacrificing for that. So if you enhance, for instance, the contrast in an image, then you will be sacrificing maybe grayscales or sacrificing resolution. Now, what you can do is that you can look at the core data of an image where you've maximized the contrast and then find some other way of improving it for your own specific diagnostic purposes. So that's not automated image enhancement, that is a conscious attempt to improve an image based upon what you see. And that happens all the time. Is in my department, for instance, we'll adjust what's known as the window level to just display those features that we're interested in seeing. But there is the answer to that question, is that we choose what we want to see. Now, if it was automated, then the decision to select certain areas that might be of interest is done by definition on an automatic basis, and I would have concerns whether or not that is accurate. So inevitably you go back to the original data, check it, and then it may or may not have been appropriate. So the automation of it is something which it's an interesting concept, but we're not at that point yet, and arguably it'll be many years, even possibly we'll never actually get for automatic image analysis or image quality. So it's an area that people are looking at, but I've got my doubts about whether we'll actually get there.
Okay. Couple of other questions which are sort of tied in together, so I'll kind of ask them together. But we have one which is, why is science relevant to medical doctors? And then sort of which medical professions then are more reliant or most reliant on medical science? So kind of tie in together.
Well, certainly the medical profession now is becoming increasingly scientific. If we want to be able to take an X-ray, we need to understand how the X-rays interact with the patient and why the image forms like it does. And all of that is a physical process. Now, the actual outcome of that X-ray becomes one for the doctors to be able to diagnose from, but the actual process for getting that X-ray, i.e. that relates to quality and risk, is very much one of a physical process. So you need to understand the science behind it. Now, the professions which utilise the key sciences, now radiology clearly relies on a lot of information about radiological science, about the interaction of X-rays. But certainly I've done work with the Royal College of Obs and Gynae as well, and what they want to know is what techniques can be used for imaging a developing fetus, for instance. What is it acceptable to use? Now, that therefore means that CT may be used, but you would usually go, if possible, for something like MRI. But even in the case of MRI, the reaction of the fetus to the magnetic fields and the changing field gradients is not fully understood, so there's risks there as well. So all of the medical professions and all the medical professions who are employed within those professions need to be fully conversant with what the risks are, and also how the science work to develop and improve both therapeutic and diagnostic procedures.
Thank you. I think the last question, it says, are doctors generally excuse legislation because the patient comes first?
That's a very interesting question, actually. There is legislation that the doctors have an ability to, it's not so much override, it's just that the legislation wouldn't apply to the patient. Excuse me. So, for instance, for you, me and most people, the environmental radiation dose that we're allowed to receive might be a few millisieverts, which is very low. It's the sort of level which you'd get from environmental exposure to radiation. But if you take a CT of a patient's abdomen, especially if they're of childbearing age, then the radiation dose to that patient can be much higher than that, 10, maybe even 20 millisieverts. So those dose limits don't apply where there is a clinical need for the administration of that radiation. So there are some circumstances where the patient is excused those guidances and legislative limits. That being said, there is also a need to ensure that as little damage as possible is done to that patient, and that's a reasonable expectation of that patient. So if the patient can reasonably argue that they didn't need a CT, an MR would have done, and they've been harmed as a result, well then legislation certainly would come into play, and it turns into a concept known as justification. The clinician, the referring clinician, has to be able to justify that radiation exposure. So in actual fact it's quite a complex situation to analyse, but generally the patient is allowed to receive what radiation the clinician can justify.
Okay, thank you. We've got one more question actually, sorry, and I think we've just got time for it. So it's more about costs and availability and why this is relevant.
Well, cost is it's a real world, and not everyone can afford the latest scanner. Now, you might imagine, for instance, in a small town, that the town might prefer to put the money that's available, the money that it's got available, into routine X-ray and ultrasound and so on, and not have available things like nuclear medicine and MRI, because it's the potential benefit to the population, the local population, and they may therefore, the patients may therefore be referred on to a larger medical centre for some of the more specialist applications, more specialist imaging. And that seems to me entirely right and proper. It may be slightly inconvenient to an individual patient, but to a population as a whole, that therefore becomes relevant. And that has a direct part to play in availability, is that if you had an MR scanner that maybe costs £500,000, but only has a few patients through every week, is that money well spent? So you may choose, again, to purchase imaging systems and radiological systems that are of maximum benefit to the population as a whole, and that will affect cost, because cost is always a driver, and it also affects the availability. And some patients may not tolerate some types of scanning. You may, for instance, end up with patients who won't tolerate nuclear medicine, who just will not accept that the radiation dose given to them is acceptable. So the availability of alternative techniques then becomes an important factor. So there's a large number of considerations, all of which have to be understood and respected.
Thank you. I think that's all the questions done. Thank you ever so much, Malcolm. I would just like to say to anybody listening, if you'd like to rate the webinar, there's a button at the top of the presentation screen for you to do that. And also, thank you once again, and thanks to everybody listening and taking part. I hope you found the webinar of use and of interest. Please do tell your colleagues that the webinar will still be available to listen to on demand, and it should be available pretty much after the live event has finished, which you'll be able to find the link to the webinar on iopscience.org/books/author-webinar. Thank you very much again, and that's over. Goodbye.
Thank you. Goodbye.